Welcome to Senadhipan Education Foundation again. Gaining knowledge is the first step to wisdom. Sharing it is the first step to humanity. We started this knowledge sharing platform way back in 2007 by releasing a brochure from our institute by Dr. Antonio Longo, who is the founder of Stapler Hemorrhoidectomy. Then we launched Senadhipan Education Foundation way back in 2012 by releasing a set of educational DVDs. It was released by Professor Sion Han Kim from Korea. Then onwards, we started having fellowship programs, 6 months and 1 year free fellowship programs with the basic and advanced laparoscopy surgery with the contact classes and hands-on training. But with the advent of COVID, we had to move to online platform, and the logo was released by none other than Dr. Palani from India. Then we started live surgeries in online platform. First live surgery was a Facebook live, that was laparoscopic anterior resection. Then we did a laparoscopy people in YouTube live, and the link was shared to the members of Senadhipan Education Foundation. Then we started having live lectures with world leaders like Professor LEROY and Junji OKUDA. We have almost 15 WhatsApp groups of more than 2,500 members. We have appearance in Facebook. We have nearly 900 members. And the first season, we did 28 webinars with world leaders like Professor LEROY, Professor Nagakawa Yuchi, and others. And actually, Professor LEROY raised the occasion twice in Senadhipan Education Foundation. First, he did a webinar on transanal TME, and then a webinar on complete mesocolic excision. So we have got global acceptance. In one of the webinars, the participants were almost 1,303. This is one of the largest virtual platforms in the world, and we had participation from more than 56 countries. We have a YouTube channel with all the webinar videos and live surgeries. We have almost 2,600 subscriptions. Today, we have 2 world leaders in the field of colorectal surgery. We are going to have a webinar on Radicality in minimally invasive colonic cancer surgery. And it will be moderated by Professor Junji Okuda from Japan. He is a professor of surgery and GA surgery, Innovation Unit Cancer Center, Osaka Medical College, Japan. He is one of the pioneers in laparoscopy colorectal surgery in Japan. He is faculty member of Japan Society of Endoscopy Surgery, and his interest is in urology and gynecology surgery, also minimally invasive. He has got 108 research articles with 2,257 citations. And these are the 2 recent publications by Professor Junji Okuda. Natural Overface Specimen Extraction Laparoscopic Colorectal Cancer Surgery, a case series study, laparoscopic resection of transverse colon cancer and Splenic Flexure, technical aspects and results. Welcome Professor Junji Okuda to this great webinar by Professor Joel LEROY, who is the world leader in colorectal surgery. He is a master trainer and innovator. He is the founder and chairman of Hanoi High-Tech Digestive Center, St. Paul Hospital, Hanoi, Vietnam. He is a leader in and pioneer in advanced colorectal surgery since early 1990s. He is a surgical expert, researcher, inventor, and educator. He is the professor of surgery in the he was the professor of surgery in the University of Lille of France. Now he is visiting professor to University of Winnipeg, Osaka Medical College, Japan, where Professor Junji Okuda is there. He is a visiting professor to IRCAD, Taiwan, Gwangju Hospital, China, Shanghai University. He is honorary fellow of Royal College of Surgeons, England. He has got a Pioneer Award in Minimalist Surgery by SAGES in 2013. And more than that, he is conducting colorectal screening programs in Vietnam that are testing about 7,000 people every day. That is phenomenal. Actually, these are the later moments we had when we met in Taiwan for a meeting. You can see Dr. LEROY, and we are really honored to have Professor Junji Okuda and Professor LEROY. Thank you for accepting my invitation. Before going to the lecture proper, all participants are requested to mute their mic on entry. If possible, kindly acknowledge by renaming your device by yours. Participants logging from outside India are requested to reveal their identity in the chat box so that the host can acknowledge you. Raise your hand if you want to intervene between talk or session. Everybody will be given permission to unmute their mic if they want to speak something after the session. If you are on a portable device, please mute your audio and hide your video. The next webinar is going to happen next Sunday, the same time. The webinar is on endoscopic management of surgical indications by none other than Dr. Rajesh Puri, and it will be moderated by Dr. Sandeep Ledkakia from AIG, Hyderabad. You can contact us in sanadiban@gmail.com. And thank you once again, Professor Junji Okuda and Professor LEROY, for accepting my invitation. I hand over the mic to Professor Junji Okuda to conduct the proceedings.
Thank you very much. I'm Okuda from Osaka, Japan. Thank you very much for giving me this kind of occasion, Professor Senadipan. I'm very honored and privileged to moderate Professor Joel Rower's lecture today. And I met him over 20 years ago, 1999. And since then, I visited him, and also I, learned a lot of things every time I met him. As far as I know, he is the best laparoscopic colorectal surgeon in the world. As you know well, he did a lot of contribution to this field, not only the expert, but also a very fabulous person. I respect him a lot. I'm always proud of being with him. Today I'm very, very honored and happy to be with him, and I very, very excited. Even right now, Japan is bedtime, but I'm very excited to have a lecture from him. I cannot wait anymore. So please start your presentation, Professor Joel.
Thank you, Junji. Before beginning, I want to thank Beju Senadipan for his kind invitation. As said Junji, I'm honored to be a member of the Senadipan Education Foundation.
We are really honored.
Yeah, me too. And we have the chance to have a group of friends worldwide using this new technology we never imagined 10 years ago or 20 years ago, when it was my first time I visited Junji in Japan, and I was invited by his boss, Professor Tanigawa, and since I have visited several times, and I was fascinated by the technique of Japanese surgeon, and particularly in the colorectal field, by Junji OKUDA. I've seen him doing more and better progress in this field of surgery. And I have learned, memorized a lot of things, and as you will see, I will present some idea he presented to me and published, and not really performed in the world, but probably will be done more and more in early case. So I have to do my lectures now. The screen is not shared. I have to share the screen. Is it right?
Yeah, please go ahead.
Where it is? It is there. Now it is shared.
Yeah. Yes.
Yeah,
Yes,
we can see it.
We can see you.
Okay. Sorry, I have to do that. So we have chosen with PROF.JUEL to speak of surgical radicality in laparoscopic colorectal cancer and how to do the best surgical procedures to cure the patient. We have a purpose in oncologic resection is to cure the patient, but also to respect anatomy and functional function. And there is a consensus. To cure the cancer, we know that we have to respect in colonic cancer the distal margin, minimum 5 centimeters, not only the bowel, but also the meso at the same level. The proximal margin 10 centimeters from the proximal margin of the tumor, and also the lateral margin minimum 5 millimeters, and also to do a good lymphadenectomy. The consensus is to achieve an accurate staging, we have to remove minimum 12 nodes, and surgeons and pathologists recommend to remove the node and to do a perfect examination of the specimen. This is a recommendation, although if the evidence base for this recommendation is weak. Consensus concerning the surgery. It is, and it's a long time ago, the no-touch technique recommended by Turnbull, and avoiding to squeeze the tumor, to avoid the squeezing of cancer cells and dissemination inside the abdominal cavity, and avoiding the manipulation with a no-touch, and during the extraction, using a protective wood sleeve, plastic wood sleeve, to protect particularly the abdominal wall. And perhaps also the technique of dissection is very important, without manipulation, and using a perfect sealing of the lymphatic, we will see later. What we have to conclude, it is necessary to have a good standardization of surgical procedure, and now the standard is a complete mesocolic excision, that is a copy of total mesorectal excision. The standardization is one of the factors to have a perfect and similar results between the leader and the fellow. What is a CME? Complete mesocolic excision when we do colectomy, oncologic colectomy. CME, there is 3 essential components. The components are, first, the dissection between the mesenteric plane and the parietal fascia, removing the mesentery within a complete envelope of mesenteric fascia and visceral peritoneum that contains all lymph nodes draining the tumor area. The central second factor, central vascular ligation or proximal vascular ligation to completely remove all lymph nodes in the central direction. And the third is the resection we have seen of an adequate length of bowel to remove involved pericolic lymph nodes in the longitudinal direction. The results of this oncologic resection will depend on the stage and the location of the tumor to perform adequate lymphadenectomy and adequate bowel resection. What is adequate lymphadenectomy in colorectal cancer? You see lymphatic nodes map, Japanese classification. This is, you can see there, courtesy Junji Okuda. This is a gift of Junji Okuda. I have introduced color too. And along the colon and rectum, we'll speak only on the colon, we have epicolic nodes that are the most proximal lymph nodes to the bowel wall. We have paracolic nodes that are located along the marginal vessels, intermediate nodes, and principal nodes. These are the epicolic nodes in green in contact with the bowel. Then the paracolic nodes along the marginal vessels. After we have the intermediate nodes along the named vessels, and those nodes will be drained to the principal nodes at the origin of the SME and IME, or it's the end of SME and the origin of IME, and drained to the para-aortic lymph nodes. Consensus is number of nodes evaluated after surgical resection are positively associated with survival of patients for stage 2 and 3 in colon cancer. These results support the consideration of the number of lymph nodes evaluated as a measure of the quality of colon cancer. Purpose of oncological resection. To achieve an accurate staging, surgeon and pathology recommend to do a perfect examination of the specimen. We will see for sigmoidectomy, example for a T3 cancer of the sigmoid loop. You see, there is the sound. Is optical, 2 and 3 working trocar, 4 and 5 are working and are refracting trocar. First, we do a panoramic exploration of the abdominal cavity, looking after the tumor and eventual metastasis. In this case, we have a pre-stenotic T3 sigmoid tumor. In this type of tumor, we have to remove the sigmoid and all the lymphatic depending on the inferior mesenteric vessels. We have particularly to remove the principal node at the origin of the IME, the node number 253, doing en bloc resection with CME. After we have found the tumor, we expose the root of the mesosigmoid and particularly anterior to the promontory, where we begin the incision of the peritoneum medial to the root of the mesosigmoid, from the promontory to the third duodenum. Then, under the vessels, we lift anteriorly. Using the pressure of the pneumoperitoneum, we provoke a pneumodissection of the retroperitoneal space and at the origin of the IME, we do skeletonization of the vessels, not in contact with the aorta, but at 2 centimeters of the aorta, removing the principal node, 253, at the origin of the IME. After dividing the IME between the two clips, we continue the dissection, mobilizing the descending mesocolon by a posterior medial approach between the Gerota fascia posteriorly and the Told fascia anteriorly to free the mesocolon, descending mesocolon completely. We continue by a dissection of the IMV trunk at the level of the division of the IME, and we skeletonize the vein. When we are skeletonizing the vessels, we put two clips, and we continue the dissection posteriorly to free the Gerota fascia from the Told fascia and reach laterally the posterior aspect of the descending column, seeing very well the Told and Gerota fascia. Continuing the posterior dissection from up to down, always anterior to the Gerota fascia and back to the Told fascia, we arrive at the level of the pelvic rim. It is at this moment I decide to free laterally the sigmoid and doing it from down to up, dividing the lateral attachment of the sigmoid and the descending mesocolon. We go slowly, and due to the posterior dissection, the plane to divide is easy to find, and we do that till we will reach the origin of the descending column at the level of the splenic flexure. Doing customization of the mobilization of the splenic flexure, we don't do too much at this moment, deciding to do more later. Before doing the freeing of the posterior attachment of the splenic flexure, I am finishing the division of the lateral attachment of the sigmoid, and I'm come back to the rectum to divide at the level of the future division of the colorectal junction. We begin on the right and posterior, and we see very well the superior rectal vessel. We will divide between clip or after sealing, as we are doing in this case. First, we do a bipolar coagulation, and after we will do a new bipolar coagulation with division. And we complete the skeletonization of the colorectal junction before applying linear stapler, endo-GIA, cartridge purple, and we divide. And it is at this moment that the vascularization of the rectum is only due to mid-rectal and low-rectal vessels. The vascularization of the sigmoid coming from distal is now stopped. We decide to divide the IMV and keeping the marginal vessels coming from the middle colic vessels. Then we come back to the column to evaluate the quality of the vascularization, and we can see the distal segment purple and the proximal pink, but it is too early to evaluate exactly the color. We will see later better the limit of vascularization when we will have divided the marginal vessels. Never do a division immediately after having divided the meso. This is how we can determine perfectly the color you see actually. It's a light purple and pink. It is necessary to wait minimum 20 minutes more to be sure of the limit of the vascularization of the colon. During this time, we will do Posterior mobilization of the splenic flexure. We are anterior to the kidney. We expose because we have free a little laterally the splenic flexure, not enough to have a tension-free anastomosis. We see the left kidney posteriorly, covered by gerontal fascia. We continue the dissection posteriorly from down to up, and we free the posterior attachment of the splenic flexure. To complete, we do laterally a mobilization because we have estimate that future area where we will do the anastomosis, we will have a tension. So we free laterally. So it's a freeing, not a complete freeing of the splenic flexure, as we do sometimes, but it is enough in 80% of cases. As you see, we do the freeing, dividing the lateral attachment of the splenic flexure and the attachment to the splenocholic ligament and of the omentum, and we will enter by lateral approach in the lesser sac. And we see down the pancreas, and we divide the attachment to the omentum that is necessary to have an opening of the lesser sac and to divide the attachment anterior to the pancreatic neck. We come back to evaluate the vascularization, and we see a big difference. It is necessary to evaluate after 20 minutes of division of the meso. If we do too early, we can do bad evaluation. And we can control after we have done the extraction of the specimen, the difference of color. In this case, we will do a side-to-hand anastomosis through a suprapubic incision with a phalangeal incision through the surgery sleeve plastic wound protector. As you see, we have introduced the anvil and we perforate the anti-mesenteric side. Advantage of this type of anastomosis proposed by John Nichols by open procedure a long time ago. We have a good vascularization with a low risk of ischemia due to a skeletonization of the distal segment when we do end-to-end anastomosis. We close the wound protector and we do anastomosis, avoiding two dog ears when we staples with a circular staple using a technique of snowshoes shape. So we will have a side-to-hand circular anastomosis with only one ear covered by the distal segment of the colon. We control the anastomosis doing air test and controlling the donuts and verifying the quality of the anastomosis by endoscopy. So this is the specimen outside, but this is a standardized procedure proposed since always by open or by laparoscopy at the beginning. But Junji OKUDA introduced a new concept from early tumor, T1, for example, T1SM2. We can do segmental sigmoidectomy with vascular preservation, lymphadenectomy for a good staging using different tools, harmonic or monopolar dissection. T1SM2 cancer, Professor OKUDA from Osaka proposed a sigmoidectomy, removing all the nodes and preserving the vascularization. This is the purpose of this movie. First step is to
find the IME and to begin the dissection, and using the same tools proposed by Professor OKUDA, that is a monopolar electrode, a spatula with a channel to evacuate the smoke, and using very low energy, 10, 15 watt, we do slowly the skeletonization of the IME at its origin in the goal to remove all the surrounding nodes that are depending of the sigmoid. We continue the dissection up to down, always in front and lateral to the superior rectal artery, using the spatula, and slowly dissecting. During a skeletonization of these vessels, we will come back to reach the division of the IME trunk, including the sigmoid trunk and the left colic artery, and we will divide the sigmoid artery trunk to be sure that we will remove, unblock the meso. We continue the dissection slowly, and division done, we do complete skeletonization of the vessels around the left colic artery, and we can see the inferior mesenteric vein that will be skeletonized using always a monopolar electrode, and this dissection is done slowly using traction, counter-traction, and exposing better and better the different branch of vessels, the left colic artery and the IMV trunk that is running either anteriorly or posteriorly, as in this case, to the left colic artery. The surrounding tissue, including the nodes, are slowly dissected, and we will see better and better the IMV trunk and the superior rectal vein with the sigmoid branch, sigmoid trunk that is going to the superior rectal vein, as we will see soon. This is slowly a dissection done up to down, and we see better and better the superior rectal vein and the different branch going to it, accessory vein coming from the sigmoid and the main trunk coming from the sigmoid loop. This is at this moment that we will see better the sigmoid trunk that is joining the superior rectal vein to do the IMV. This trunk will be skeletonized and divided. This is at the end of the dissection with the parietalization of the vessels. IME trunk, superior rectal artery, left colic artery, inferior mesenteric vein, and the stump of the sigmoid trunk that was divided recent. We divide now the attachment to the meso and the accessory root of the mesosigmoid is progressively divided. This is the moment we will continue the procedure, doing a sigmoid resection and doing distal and proximal dissection. We can limit, because we have removed completely the meso and the nodes.
So this is another approach, respecting maximum the vascularization, but removing all the nodes, doing similar than complete mesocolic excision, removing all the main vessels. But sometimes we have big tumor fixed to the surrounding tissue, particularly the abdominal wall. And we have to respect, as I said at the beginning, a lateral margin. We cannot divide in the tumor. So this is a case of big tumor explosion of the abdominal cavity, and we find the tumor after exposure at the distal part of the descending column. As we see on this picture, this location requires an oncologic left colectomy, removing the descending column and the sigmoid and all the nodes depending on the IME, and particularly the principal node 253. We begin first by the dissection of the IME at its origin and divide it between two clips to grasp the distal segment and turn it laterally and lift anterior to expose better the superior hypogastric plexus and the different branch attached to the vessels. We continue the dissection from medial to lateral, staying in the right plane between gerontoplastic fascia and torch fascia, avoiding injury of retroperitoneal structures, as in this case, where we see very well the genital vein. It is why we don't hesitate to come back to the IMV trunk, lateral to the right angle, and we expose the pancreas and continue the dissection from medial to lateral, anterior to the pancreas. Then we dissect the IMV trunk to expose it very well and to divide after putting two clips and grasp the mesocolon to expose perfectly the retroperitoneal space and dissect it from the anterior aspect of the pancreas till we reach the pancreatic tail, dividing the transverse mesocolon attachment anterior to the pancreas. We continue the dissection down in the retroperitoneal space, but we have the feeling of the fixation of the tumor on the posterior side. This is why we go laterally and we confirm the fixation to the peritoneum, and we decide to remove a patch of peritoneum fixed to the tumor because we have a doubt concerning eventual perforation of this tumor. And we don't grasp the tumor, but as we see now, we are grasping the peritoneum to have a good traction. And we continue the dissection down to up laterally, removing the peritoneum fixed to the tumor. And we do that in the retroperitoneal space. But to complete, we have to come back medially to see the posterior fixation better. Fixation to the gerontoplastic fascia. It is why we will remove the gerontoplastic fascia fixed on the back of the tumor. We see very well the fact of the perirenal space, and we remove the gerontoplastic fascia fixed to the tumor. When we have free this part of the colon, we continue the dissection by lateral to complete the mobilization of the descending colon, dissecting up to splenic flexure laterally. Then we go to the lateral attachment of the transverse. So we have seen different recommendations respecting proximal, respecting distal margin, respecting lateral margin, doing primary vascular approach or central vascular approach. But we have to do easily in left colectomy, sigmoidectomy, but in right colon, we can have some doubt concerning the limit of the lymphadenectomy we have to do.
When I perform a laparoscopic right colectomy, I stay between the leg of the patient in supine position, head up, left arm along the body. And we use 5 trocar. The trocar 1 and 2 are used for optical. The trocar 3 and 5 are used for working. And the 4th trocar is a trocar to retract cephalad. The transverse column and omentum. First, so we do a panoramic exploration of the abdominal cavity to verify if there is no metastasis. And after retracting the transverse mesocolon and omentum cephalad, we begin the procedure by lifting anteriorly the ileocecal vessels and opening the mesocolon just under the ileocolic vessels till we open the retroperitoneal space and we see the third duodenum. Rapidly, we go in front of the anterior aspect of the superior mesenteric vein and we slowly do a skeletonization of the ileocolic vessels that will be clipped and divided separately or together. Then we continue the dissection down to up, retracting the duodenum and the pancreas head posteriorly. Then we go medially, always in front of the SMV, and we can see different branches of vein coming from the right colon. This is an accessory right colic vein going directly into the trunk of the SMV. We continue the dissection without changing our positions in the direction of the transverse mesocolon, and it is at this moment that we can see the middle colic artery divided into branches, one right, one left, and we will skeletonize the trunk to remove eventually some nodes and divide the right colic branch of the middle colic artery. We have now to dissect the gastrocolic trunk of Henle, and we will dissect and skeletonize the different branches of this trunk, the right colic vein, the gastromental vein, the pancreatic vein, and the gastrocolic trunk of Henle. We divide first the right colic vein that is divided using the thunder bits that seal the vessels. Gastro-omental artery, right gastro-omental artery that is divided too, always using thunder bit. When we have finished the division of the vessels, it is time to continue the procedure dividing the transverse colon and what.
So you have understood for right colectomy, there is a discussion between Japanese school and West Country school, where we think it's not necessary to do lymphadenectomy of the mid-transverse vessels, but doing only on the ileocolic vessels. But this is probably true for the second ascending colon and hepatic flexure, but more risky if we have a right transverse colon. It is why, as we see on this picture, concerning the nodes, you have different color. For the hepatic flexure, the right transverse colon and mid-transverse, the nodes, the lymphatic drainage is mainly through the mid-colic and around the mid-colic vessels. But it's not only for the mid-transverse enough. We have the right omental vessels because we will remove the great omentum, and the left omental vessels where we have nodes attached. So we will have to remove the nodes depending of those vessels. How we do? This is a mid-transverse tumor operated in emergency for bowel obstruction, and we did protective stoma close to the tumor on the mid-transverse. And 1 week later, we came back, and as you see, we have a lot of nodes around the ileocolic vessels and mid-colic vessels. How we do? We do a complete dissection, as you see, as we do usually in right colectomy. We dissect anterior to the superior mesenteric vein till we have attached detach all the surrounding tissue, including the nodes around. In this case, we continue the dissection, dividing the ileocolic vessels and finally completing the dissection by medial posterior approach, not changing our position, but only manipulating the tissue with a soft manipulation, and we progressively free, and you see a big node around, it's inflammatory nodes around the ileocolic vessels, little attached to the pancreatic head, and we free slowly the pancreas and the duodenum. We continue the dissection by posterior medial and posterior down to up dissection to free all the attachment of the transverse mesocolon to the pancreas and duodenum till we will reach the superior edge of the first duodenum, and dividing all the vessels we have described in the previous movie. These are the ileocolic right omental vessels we divide. We will divide because when we do a complete resection of the transverse colon, we remove also the omentum, the great omentum fixed to the transverse colon. So we do it by posterior approach. We continue dividing the right colonic vessels, vein, and we continue medially from right to left to detach all the transverse mesocolon and removing the nodes anterior to the superior mesenteric artery and removing the mid-transverse vessels. And we will detach completely the omentum from the stomach. And we will divide laterally the left omental vessels. Same for segmental tumor of the splenic flexure segment. We will do similar approach. We can do segmental resection respecting the main vessels, particularly the IME, IMV. As you see, we have dissected, skeletonized the IME, dividing the left colic artery only, freeing the IMV, respecting by medial approach the trunk to have a good drainage of the sigmoid and a good drainage of the rectum, venous drainage. It's better to avoid functional problem. We see very well posteriorly the gerota fascia, and we will free the gerota fascia from the tall fascia. For this tumor fixed to the meso, we have, and to the small bowel, proximal small bowel, we decide not to free the small bowel, but to resect, unblock the tumor. And for that, we divide the segment of bowel with a stapler without opening the bowel at this moment. And we let this segment fix to the tumor. We have to continue dividing the left, this is an accessory left colic artery or left branch of the mid-colic artery. We divide and we continue the dissection by medial posterior approach anterior to the pancreas, just at the edge of the pancreas, and we reach the left omental vessels. We will see very well now the vein and artery. We will divide between clip for removing the omental segment fixed to this segment of bowel, and to have a better oncologic resection, because we understand if there is cancer cells in the omentum, we will have a risk of invasion. How to improve adequate lymphadenectomy in colorectal cancer, in colonic cancer? Using a new energy device, I will say as robotic. I don't think for colonic it's a real advantage. Using ICG, adapted device to seals to facilitate surgical procedures. As you see, this is a picture of dissection of IME at its origin. I'm using monopolar scissors, and I'm cutting without sealing. And what we will see now, this is a lymphoray. That means lymph is falling inside the abdominal cavity. That means if there is cancer cells inside the lymphatic, we will have a contamination of the abdominal cavity, and we know that there is carcinomatose. Now, majority of surgeons, for doing lymphadenectomy, use new energy device, harmonic, sealing device as ligature, but it's better or you put a lot of clip, or you use a sealing device that will facilitate the surgical step. Using ICG. Why using ICG? For the research of the sentinel nodes, for the localization of the nodes, doing a mapping of the nodes, or improving the quality of surgical lymphadenectomy. The ICG was recently proposed for sentinel nodes and vascular evaluation in colorectal laparoscopic resection. The concept, the principles of sentinel lymph nodes biopsy is well established in melanocarcinoma, in breast cancer, where the aim is to avoid unnecessary and potentially morbid lymphadenectomy. So it is to change, adapt surgical procedures. Unlike these two malignancies, where lymphadenectomy is a separate procedure of the surgical resection, lymphadenectomy in elective colorectal cancer is typically performed as part of a single surgical procedure. We will not change our surgery. For doing a mapping to find the nodes where they are, this is why we can use, perhaps, if we don't know where are the nodes, but as I have demonstrated, when we do sigmoidectomy, we remove the vascular package with all the nodes around, except in early case when we can change. This is what we can see when we do this mapping with ICG. But if it is only to see that, why using? It's very expensive. We have to change the camera, and but I think we can use it to improve the quality, to evaluate the quality of lymphadenectomy. Same patient, we did lymphadenectomy as usual. We control after, and what we see around in front of the aorta, we have also a positive node like this. We have not imagined there was a node at this level, and I decide to remove it with the ICG control to be sure I will remove all the lymphatic tissue. In conclusion, in Europe and Asia, surgeons have adopted complete mesocolic excision as the optimal approach for colonic cancer surgery. The concept of CME is like the TME for rectal cancer. With CME, we do a radical approach in colonic cancer, and we consider it is optimal now. This perhaps may not be necessarily applied in early stage of the tumor stage, as we have seen with JUNJI. And respecting a good standardization, we will have by laparoscopy similar results than for the resection as we have in open surgery with larger and more morbid surgical procedures. This is what I wanted to present to you. Many thanks to Beju for his invitation, and I'm open to speak, to answer to your question.
Thank you, Professor LEROY. That was a wonderful talk, as usual. This is the third talk you are giving in the Anatomy Education Foundation. I congratulate for the excellent videos you have shown. I hand over the mic to the moderator for the next proceedings.
Oh, thank you very much, Professor Joel. I'm totally convinced with your meticulous approach and very fabulous technique, especially depending on the tumor stage and tumor depths of invasion. As you said, especially for the T2, more than T2 cancer, T2, T3, T4 cancer, at that time, CME is gold standard, like TME for colorectal cancer. I totally agree with you. And as you said, T1 cancer and not so radical operation is not necessary. Is that right?
It is what you demonstrate, and you did the evaluation of those techniques. And as you have demonstrated too, we can do large lymphadenectomy, respecting vascularization, and doing large enough resection, keeping good vascularization for the proximal distal segment of the bowel, and keeping good functional results, because when we keep a good vascularization, we have no venous stasis, for example, in the sigmoid, in the rectum, time of adaptation. So I think it is a good strategy, but it's large, but with a good preservation of the anatomy, and it is better for the patient concerning functional results.
Yes, I think so. And how about the preservation of IMB? As you in video, very, very good, fabulous approach, technique to preserve the IMB for left colorectal cancer, colonic cancer. However, sometimes very difficult for the, not expert surgeon, very difficult. What is the indication to preserve the IMB?
Personally, I think, I will not say it's always, but this is one of my goals. It's to preserve the main vessels. I understand your question. It is particularly true in West countries. People said, and it's why I have chosen patients with fat to present. They said, no, we cannot do. I said, but in Japan they do. Yeah, but they are not the same patient. So I did demonstration, even in obese patients. If we wish, we can. But I can understand that it's sometimes difficult. But slim patient, sometimes it's not easy. When we have to dissect around slim vessels in slim patient, it's not so easy. We have to use the OKUDA cannula. When I'm operating with your cannula, people said, what is this cannula? It's a spatula from Junji Okuda with a suction, so we can have the possibility to clarify the surgical field eventually, but there is not a lot of smoke. But as you know, Junji, people are more impressed by the monopolar dissection. When I remember when I was in Brazil, I did a demonstration and people said, how you can do with monopolar? We all use harmonic. We cannot do. No, it's not true. It's more precise, and people are fascinated by the simple tools for doing. But we have to know how to use very well the energy. We have to know how to manipulate, soft manipulation, and to know the anatomy. Knowledge of the anatomy is very important. And sometimes, and we know, anatomy is available in 60% of cases. It is always changing depending of patient. But if we can, it's better. For benign disease in sigmoiditis, I recommend to do. Some people are saying we cannot for the vein. For the artery, we can. And if we don't do also for the vein, venous drainage, you see, if you keep a big vessels, we have a big flow in the sigmoid, in the rectum. 80% of the vascularization of the rectum is coming from the hyme. If you have a big flow, after the drainage is done where? Only distal drainage, venous drainage, via mid-rectal vein and distal rectal vein. And you will have high pressure in the venous network. So it's why I think keeping the HMV will give a good venous drainage. And you can have some edema in the sigmoid, some edema in the rectum. I have operated a patient that had very young agenesia or thrombosis of the superior rectal vein. Believe me, there was a big network of venous dilatation with regular bleeding in the rectum. So this is a real important. This is a perfect demonstration if we ligate the HMV without ligating the IME. You will have a big pressure. So if we can keep it better.
Yeah. I agree with you.
We have to train for doing.
Yeah. So
it is why I say if I cannot keep very well the vein, I prefer to divide the HME because I will do sigmoidectomy at the same time and do anastomosis on the rectum.
Okay. Yes, I learned that thing from you. Since that time, I will preserve the IMB as far as possible, as much as I can. Yes, I totally agree with you. Okay, so the next question is, how about the augmental vessels dissection? That's sometimes very difficult, especially the right side, right epigastric vein and artery, and left side is left epigastric artery vein. What is the key to accomplish those maneuver safely?
Good question. First, because it's not proposed by a lot of people, but when we remove the omentum, particularly all the great omentum, the vessels, why we remove the omentum? It is because we suppose there is a risk of nodes inside. So if there is nodes, they will have a drainage along the omental vessels. And there is two main omental vessels. We have two possibilities. You do the by superior approach. You go above the transverse colon and you try to dissect the vessel by above, on the right, on left. So we have to open the attachment to the stomach and we have to find the omental vessels. As you have seen, it's not the complete movie. I have a complete movie. All the movies you have seen are available on my channel, YouTube. You have all the procedure longer. And I do by medial posterior, by posterior down to up. I lift completely the omentum and the transverse column, and I lift the transverse, and as you have seen, we will see all the vessels visible. On right, we will see just under the first duodenum, the right omental vessels, vein, the artery, the vein artery, and same on the left. We will continue the dissection anterior to the inferior edge of the pancreas, so the root of the transverse metacolon will be free, and we arrive on left, and we have seen better with my segmental resection of the splenic flexure. We have these vessels visible. And I remember I have diffused this movie in YouTube, and there was a lot of comment, people saying, the first time I see so well the vessels, but they are really well visible. When we know, we look after, we see.
Yeah. So how about the opinion about you usually use a down to up approach, and some surgeons recommend the up to down approach. Do you have any experience to up to down approach?
For what? For
doing the right flexure takedown or left flexure takedown?
As you know, I try all the technique. At the beginning, I tried the technique, particularly for the right colectomy. I tried to do a mirror of left colectomy. I was staying on the left side. I stay on the right side. I stay between the legs. Why I have chosen a procedure, even if we have to know all the procedure, because sometimes we have complex procedure, we have to change the position of the surgeon and the team. But my standard is how to do with a minimum of manipulation, minimum of change. So when I'm between the leg, I'm doing my procedure down to up, my assistant expose, retract, nobody is moving, and I'm doing my dissection from down to up medial, and I do 80% of my procedure without manipulation or movement.
You are one of the surgeons who sits and operate, is it?
What?
One of the surgeons who sits and operate, is it? You sit between the legs, right?
I stay between the leg in 90%.
Yeah.
In complex procedure with fixation of the cecum after surgical procedures, complex obese patient, difficult to manipulate. So we know in surgeries there is never 100%. So we have to know how, and don't hesitate to change the position. But my position is between the legs. And I've seen recently a comment of Daniel Popovich from SAGE's Master Colorectal Group. He was surprised, and he tried with the robot, because for robotic surgeon, if you are disposing the equipment for doing from down to up, you have not to change a lot. You are going straight. This is my position since always, and Giovanni Dapri is doing his procedure by suprapubic single port, and he said he's using my concept from down to up, exposing and going straight without manipulation. This is the only advantage. So it is what I try to do in a maximum of surgical procedure I'm doing.
Thank you. And my last question is talking about ICG. As you said, ICG has two advantages mainly. One is lymphatic mapping. The other is vascularization, confirming the vascularization. And nowadays, ICG is very common and popular in many institutions. And as you showed, demonstrated in this video, especially the lymphatic mapping is to avoid the metastatic lymph nodes left inside. And that is, you think this kind of maneuver is standardized procedure in the near future?
It's, I think, as I have explained, it's particularly, in my opinion, because with 4-key video, vascularization can be evaluated very well, and if we respect also the protocol, surgical protocol, very well with a 4-key video camera. But what you have seen, because I have some secret, what you have seen concerning the mapping, if you try to do, how you will do? You will do injection of your ICG around the tumor, is it right? And you think you will see the node. Yes and no. You will see the node around the tumor, not too far. And or too far, but with the first nodes changing their color, erase rapidly. Why? Because the molecular weight is very light. So ICG is going very fast. So what you have seen, it is an error. We did the day before, because the patient was scheduled one day and we cannot operate him. We operate the day after. So we did the injection before we were thinking we will operate the patient. And we operate after one day. And we had this beautiful mapping. And I'm thinking, but you will do. You will do because you do research. Well, I am thinking we have to increase the molecular weight of the ICG. Fixing, and it is in the literature, fixing to albumin. You will have higher molecular weight. Migration will be very slow. And you do the injection the day before. For what it is important? For right colon tumor or hepatic flexure or second, you know there is a discussion. Is it necessary to do lymphadenectomy of the mid-colic vessels? In Japan, we say yes. We say no, we don't know. So if you do this technique with slow migration, we have to calculate exactly which molecular weight we wish. The day after we do, or 2 days before, depending on the molecular weight, we will operate the patient. And what we will see, if we have blue or green nodes, only ileocecal, it's not necessary to do mid-transverse, middle colic lymphadenectomy. If probably for second, it is what we will have. If we have hepatic flexure, we do, and we have middle colic and ileocolic, or we have only middle. We will do both. And this is one of the possibilities. You remember I said ICG for sentinel nodes. It is not for sentinel nodes, but it is for doing which lymphadenectomy? Ileocolic or large ileocolic and mid-colic. And this will be interesting to do, but till now, we have no paper, no research saying which type of ICG we have to do injection for doing a perfect mapping, and when we have to do. And it is a problem also of, because when we do for vascular, it's not similar for tumor.
Oh, so as regarding the vascular anatomy, especially ICG is mapping is recommended to the left flexure tumor. Left flexure is very, very difficult to identify the, vessels accurately. Cause on a left colic artery or accessory middle colic or left side of left branch of middle colic, sometimes difficult to identify. At that time, the ICG mapping is recommended.
Yeah.
We have Dr. Rajesh TK from UK, who is a colorectal surgeon, joined here. Dr. Rajesh, can you please unmute?
Yes, Baiju, can you hear me?
Yeah, we can hear you. What's your opinion regarding the ICG?
Professor, good evening.
Good
Professor
evening.
LEROY, nice meeting you again. It's wonderful to see your videos. Excellent demonstration of the CME, CVL, and left-sided colonic resections. And it's a nice lecture for the juniors. It's a feast for the eye. It's a feast for the colorectal surgeons. And thank you, Professor Junji OKUDA, to join us and give us an insight. And my few thoughts about I've been a colorectal surgeon for 20 years, and we have done a CME and CVL continuously. As you say, the CME is the standard for colonic resections. And I do the same technique, do the CME and central venous ligation and Henle's loop isolation and clip the vessels. I do from bottoms up because it's a straight line. It's like a motorway. You see the tributaries going and you go straight and clip all the tributaries out. But that is a norm. And from the Norway, the studies have come. The cohort studies of comparing CME with non-CME shows that CME shows a better outcome in all the stages. UACC 1, 2, or 3. Even the early cancers, the CME is better outcome. They say 18% cancer-free survival with CME. So I do CME for even early stage cancer. The exclusion for me is only if the patient is comorbid, a lot of comorbidity, octogenarians, 80+ years. There I do try to do a D2 resection. Rest of all, I do CME, even in the stage 1, 2, 3, all the cancers. So that is now people are learning, and the initial fear was there will be a venous compromise and produces a lot of venous edema to the small bowel and anesthetic leak rates. But we have compared in our studies, but there is no increased complication rates with CME group. So everyone is learning CME, and we are also trying to do robotically because the 3D pictures will give us more visual effects on the superior mesenteric vein. So this is everyone is standardizing on the CME, and hopefully my video has been accepted from the American College of Surgeons to show the CME, where I don't use any clips because we know Thunderbeat is a very good device to take the artery and vein by itself. It has got both bipolar and ultrasound. My thought process is ICG. You mentioned on the left side of colonic resections, you wait for 20 minutes to see the color change. My question is, can you use ICG for the vascularity and do the resection intracorporally with the help of ICG? What is your thoughts, Professor LEROY?
A lot of comment. No, it's. I will begin by the end. Personally, I don't think ICG, particularly in Asia, improve the quality of the results concerning ischemia, and particularly if it's fistula. Your fistula rate is so low that I have difficulty to imagine you can do better and you can demonstrate you can do better with ICG, particularly if you have a good camera with a good picture. And as you said, I recommend in the step of surgical procedure to divide the meso and to evaluate 20 minutes later. If you are speaking of ICG, I was speaking with the team of IRCAD, and finally they conclude we have to wait 20 minutes to evaluate the vascularity when we do injection of ICG. So we have same problem. We cannot evaluate dividing the meso and doing immediately because there is a risk of ischemia later, and we can evaluate better after. So this is my opinion. And if you can demonstrate that you have better results concerning ischemia, I'm open. And this is not what I have seen, because since I was operating in Vietnam, I've never seen so low rate, so I'm perhaps better, of fistula, particularly due to ischemia.
Excellent answer, Professor. The next question is, now we are moving towards a lymph node ratio. Previously in UK, we say that 12 lymph nodes is more than sufficient, but I don't accept that 12 lymph nodes. I believe that the ratio is important than the 12 lymph node concept. So we are looking into the positive lymph nodes divided by the number of lymph nodes you gathered. That's a lymph node ratio will be the near future. What do you think about this lymph node ratio rather than 12 lymph nodes?
As I said, there is a week concerning the recommendation concerning 12 lymph nodes. But what we know, what I'm sure, if we do a real complete mesocolic excision, removing nodes, I'm excluding the rectum, because sometimes after radiochemotherapy, you will have less nodes than you imagine, or you did a perfect surgical procedure, and it is due to the neoadjuvant treatment. But if you do perfect removal, as I have said, there is consensus, surgeon and pathologist. Yes, when I was watching, inviting by Junji and Professor Tanigawa, I was immediately after surgical procedure in the lab to do examination of the specimen. And they found a lot of nodes. 12 for them, it's very low. Yeah. Because they are looking immediately, and they are looking with the pathologist, and they do a perfect examination of the specimen. This is the first. So the number of nodes is not really a criteria. It depends where it is. And I have seen some people saying, I have in my mind, I will not say the name, they have minimum 30 nodes. Yes, they remove the segment of sigmoid, they remove the left colon and transverse colon, and they do examination of all the nodes of the specimen. But these are not the nodes depending on the tumor. It is not what we want to see. We want to see all the package, vascular package of the specimen and the nodes depending on the localization of the tumor, not of the descending colon, transverse colon, and right colon, and we have 30 nodes for, oh yes, it is sure. Yeah. We will have a lot of nodes.
Yeah, agree, Professor, that lymph nodes are important, and it's depend upon the pathologist as well as the new adjuvant treatment which they have received. Next concept which I'm thinking, what you said was IMV preservation. I'm an anatomy teacher, I teach the students that always a vein is accompanied by an artery. The reason behind veins will not drain blood. It is the help of the artery, the venous blood is returned back to the heart. So for a superior mesenteric vein has got superior mesenteric artery, inferior mesenteric vein has got inferior mesenteric artery, splenic vein has got a splenic artery. But in your case, if you are clipping an inferior mesenteric artery and leaving behind the inferior mesenteric vein, I feel the blood may not drain and it will go for thrombosis immediately. You are skeletonizing the inferior mesenteric vein and leaving it just like that without any support to get drainage happening. So I'm worried there might be IMV can go into thrombosis immediately. So I would ask Junji, you can do a Doppler to see all these veins which has been left without any support of artery, whether how much they drain, or it is a exercise which is done for the purpose of doing it. We need to have an evidence to say how many IMV which are without support of IMA remain patent after a few days. Can you answer this, Professor LEROY?
I thought you said keeping the IMV and dividing the IME?
Yeah.
I never do that. I divide both. I said, if I have to divide the IMV, I prefer to divide the IME.
So when do you preserve the IMV?
I preserve for benign disease.
Okay.
I preserve in early case. You have seen the demonstration. I tried to show the demonstration. Originally, Junji was not keeping the IMV, but now I suppose he tried to keep the IMV too. He was dissecting the IME perfectly to remove all the nodes, and thinking it was easier to remove the lymphatic, removing the vein. But I have demonstrated we can do two. We can do a preservation of the main vessels and do similar resection than the CME, keeping the main vessels, IME, superior rectal artery, superior rectal vein, and IMV.
Yeah, but it's a good technique, but we need more evidence to support that.
No, you are right. But Junji did publish a paper concerning this technique and saying same oncologic results than large resection. Is it right?
Yeah. Yes, it depends on the tumor stage, cancer stage, and tumor depth of invasion, especially as you said, the T1 cancer. And the CME technique is not necessary, and we can preserve the vein and artery and vein like that. And especially in the near future, the ICG will show some, evidence, as you said, if immediately thrombosis occurred or not using the ICG.
Thank you, Professor LEROY. Yeah, that is
you have another comment concerning difference between D3 and CME. Honestly, I don't know. I don't know because I was doing CME thinking I was doing D3. And I don't know if you have information. Perhaps. When we were speaking of D3, majority of the surgeons open were doing D3, but they were not beginning by primary vascular approach. They were beginning by mobilization of the colon first, manipulating the colon without ligation. I think this is perhaps the difference. And since always we do CME, but we don't know what we're doing. Because when I was in Japan, before Owenberger publication, I was seeing Junji doing CME. Why? We don't touch. Finally, we respect the Turnbull principles from Cleveland Clinic since we do laparoscopic surgery, avoiding to touch the tumor, avoiding to manipulate the tumor before doing ligation, before doing division of the bowel, and doing the exclusion. So we were respecting finally the Turnbull principles. And it is, for me, CME is primary vascular approach at the origin of the vessels. Central vascular approach first, and doing a complete mobilization between posterior fascia, primary peritoneum, and told fascia. That is the mesocolon. What is for you the difference between D3 and CME?
Complete mesocolic excision. There's all the three components. You do a CME, CVL, and proximal distal resection. All together completes as a radical surgery for the right side colon cancer.
No, but D3. You said D3.
D3 is apical lymph nodes. What you said was apical or central lymph nodes. Removal of the central lymph nodes, we consider as a D3.
Well, honestly, I never did. I never did. I never did.
We have surgeons from different regions.
Yeah, in
India,
we call it as D3.
Yeah.
India we call it as D3. But excellent, excellent discussion. Thank you, Professor Leroy and Junji Okuda. Back to Baiju. Baiju, thank you.
Thank you, Rajesh, for joining. Professor Junji Okuda, can you please take the questions in chat box for Dr. Leroy to answer?
Oh, thank you very much. Today we have a very good discussion, and because Professor Joel Leroy's lecture is excellent. Because we can discuss many things. In the near future, we will demonstrate much more things. At that time, we learn something new a lot from him. Thank you very much for joining us.
Yeah, Professor, there are some questions in the chat box regarding does descending or sigmoid colon always take the curve of the sacrum before anastomosis to say splenic flexure is fully mobilized? You can see the last question there.
What was your question?
Does descending or sigmoid should always take the curve of pre-sacrum before anastomosis to say splenic flexure is fully mobilized? What he meant is actually when you do the anastomosis, whether the colon has to, he is talking about a low anti-recession, whether the colon has to lie on the presacral curve or can lie straight.
Yes, yeah, you have seen today, I was speaking of radicality in cancer colon surgery.
Yeah.
So I have focused on technique of dissection of component for a good oncologic resection. I have not focused on anastomosis, even if I have shown, but if you wish, I have a complete lecture concerning colonic colorectal anastomosis. This can be an interesting discussion for explaining how to do good anastomosis in colorectal procedures. So I can try to answer, but it's too long. We have so many things to say when we are speaking of anastomosis, but it is for me another topic. I have not focused on that. I did a small error. I have shown a small anastomosis because
our discussion is purely colonic, not a rectal cancer.
I have focused on proximal, distal, lateral in advance, reducing the dissection to be and being oncologic, the OKUDA technique, and complex procedure when we have tumor localized on the mid-transverse, what we do, and on the small segment, can we do oncologic respecting radicality?
Yeah, there is another question from Jagannath Dikshit. He's asking whether this 15 centimeter on either side of the tumor is specific, or do you have any other measurement for that?
Any what? For what?
No, means he says that always said that 15 centimeter on either side of the tumor is adequate for a radicality resection. Is it true?
Honestly, I not well understood.
Probably
No,
I think you have very close of your microphone, so you have echo. Perhaps it's better for Japan.
He's
Perhaps.
asking, it is said that 15 centimeter on either side of the colon, either side of the tumor is adequate for a resection. Is it true, or you'll have to depend on any other measurements like the vascularity, the segmental vessels and all?
Yeah, it's a, no, when the consensus, and if you see Junji operating, is operating with the rules and is measuring the distance between the distal segment of the tumor and where he will do the division, and for the proximal too. But it will depend. This is the minimum, and not only of the bowel, but also of the meso. We have to remember, if you have a conical division of the meso, you will have less. So it is 5 centimeter distal, 10 proximal. But it will depend also of the vascularization and how to keep the vascularization. I have tried to show, for example, for the splenic flexure, segmental resection. We have not spoken of hepatic flexure segmental resection. I have seen Junji doing one, but I think majority of people are doing right colectomy. It's why for the public, for beginner, I have shown the vascular dissection during right colectomy.
Yeah. Yes. Yes.
What do you prefer for anastomosis? The hand-sewn anastomosis or intracorporeal anastomosis?
For right colectomy, I will use side to side isoperistaltic in anastomosis with a stapler and complete with running sutures to close the orifice where I have introduced the stapler. For distal colon sigmoidectomy, I will use a circular stapler. For ileocolic anastomosis after transverse right colectomy, and right colectomy, I will use a stapler, isoperistaltic. But majority can be done inside, but sometimes we do outside because it's faster, easier. Particularly for beginners, we have always a possibility to have a good challenge. We can do all handmade, but it is only the robotic surgeons that love to say that we can do now handmade.
Yeah.
Yes, why not?
But as Professor Joel said, even in laparoscopic colon surgery, nowadays intracorporeal anastomosis is getting common. Yeah.
Yeah.
It's particularly important because in India, there is a lot of obese patients. It's particularly important in obese patients. Why?
Yeah.
Because if you have a thick abdominal wall, if you wish to do anastomosis outside, you will have to mobilize more. You will have to do larger incision to avoid traction on the meso and with a high risk of ischemia. So doing inside in obese patient, it's a factor of good results and less risk of fistula.
Yeah. Yeah.
Yeah,
Exactly.
Dr. Rudra from Delhi is an oncosurgeon, has joined Dr. Rudra, do you have any questions to ask or to add any comments?
Yeah, Professor Leroy, I think it was wonderful demonstration of the videos and the concept of CME in the line of TME. So my question will be that TME is now equivalent to CME. So same thing is now with CRM with RSM. So CRM is circumferential resection margin. RSM is retroperitoneal surface margin of the colon. So it is very important to maintain the RSM. So RSM is now radiologically proved with CT scan and MRI. You can see the RSM, how much the tumor infiltrates beyond serosa posteriorly, especially for the posterior tumors. And to ensure that how do you maintain the RSM posteriorly during your posterior dissection? That is number one question. Number two is after the vascular division, when you divide before you divide the colon with the stapler, do you wait for some time to see the changes in vascularity or color of the colon? Then you divide the colon, or you just blindly do it proximally without waiting for any color changes in the colon? So these are the two questions.
I will begin by the last comment. When, as I said, if we have a lecture on anastomosis, I will explain to all the...
We will have another lecture on anastomosis.
No, when I do dissection, as I said, and my friend Frédéric Bretagnol said, he's dividing rapidly the meso, where he's supposing to do the proximal division. And we do the distal division to avoid the retrograde vascularization. So we have normally two distal division of the meso, proximal and distal, and normally ischemia. Because if you keep the distal, you will have a retrograde vascularization, you have difficulty to see. But when you divide, immediately you see nothing. I'm not speaking of ICG. It is why I never begin by the mobilization of the splenic flexure. It is later I will do. It will take 20 minutes. So I'm not with calculating exactly 20 minutes. So time to do the mobilization, it is what I said in the movie. You have not perhaps remember, but after I have finished to mobilize, I come back and I watch, and there is a big difference. I have explained the movie you have seen. We will do the division, but we don't know exactly the quality of the vascularization. If I do a control at this moment, it's why I say never do the division immediately after you have done the division of the meso. Proximal, distal, both. To have it, both, you divide both, not one, not the proximal, not only
both.
And you come back, and it is at this moment you will see the big difference. So it is 20 minutes. I said 20 minutes because I have a movie showing 5 minutes, 10 minutes, 20 minutes, the big difference of color changing. So this is
very nice.
What I do. And I'm not losing time. If I have finished my procedure, I have divided the meso, and I wait 20 minutes, nobody will do. Nobody will do because nobody we should wait 20 minutes.
Yeah.
So the first comment was on
retroperitoneal surface margin of the colon for posterior tumors.
Yeah. Only to remember, we are speaking to beginner, T4 tumor, it's particular. So it's not recommended to begin by T4 tumor. No, because, and I have published with Frédéric Bretagnol the results on T4 tumor. It is interesting. Finally, we have similar results doing open or doing bilaparoscopy. But we have to respect Turnbull principles. You have seen the T4 tumor I have presented to you, fixed posteriorly. I have another one on the splenic flexure. It was fixed to the small bowel.
Small intestine.
It is different. And I have shown we do vascular dissection. We evaluate first if there is no carcinomatose, not a contraindication, oncologic contraindication to do bilaparoscopy. So we do vascular approach. We do distal division. We do proximal division. And after we go to dissect the segment with the tumor. I have done bilateral. I have not divide and touch the tumor. And I have removed, it's not difficult, you remove posteriorly, you remove a patch, you remove the fat fixed to the peritoneum. As I explained, we remove gerota, the fat in the gerota fascia fixed to the tumor in doubt. There was finally no invasion, but we don't know. So if you have a trick, I don't know, perhaps ICG, if we can see with ICG or other possibility, the infiltration of a tumor, it will be interesting. Because perhaps, but we have to do injection inside the tumor. It will not be exactly the infiltration to remove around the tissue. But if you have solution by imaging to remove perfectly, respecting also the anatomy behind, because you have nerve, ureter, and other posterior organ to respect.
Yeah, my point was also that even if you have a T2 lesion, then when you go for posterior dissection, you stick to the organ, adjacent organ, so that you get the maximum retroperitoneal surface margin. Because the embryologically, there is also a posterior mesentery beyond the colon, between the colon and the gerota fossa. So if you stick to the gerota fossa surface, you will get even posteriorly some mesentery on the posterior surface of the colon, even in T2 lesions.
No, but when we do medial approach of the colon, if the colon is free easily by only traction, I'm sure there is no invasion. If there is a doubt with a posterior fixation, I remove the gerota fascia.
Yeah.
Yeah.
Yeah, Dr. Leshmi, do you have?
Thank you. Thank you.
Good evening, and Dr. Leroy, as usual, excellent lecture. And every time we see your lecture, we learn new things. And one last question: if a patient is having two lesions, one in the sigmoid and one in the descending colon, with minimal pericolic lymph nodes, do you have any fear that sometimes after resection we have inability even after mobilization to anastomosis? Did you have any occasions like that, or do you have any change of strategy?
I think it's an easy case, what you propose. Left colon and sigmoid, it's a left colectomy. Easy. It's if you have transverse and sigmoid, it's more complicated. But left colon and sigmoid, I think, Junji, you will do left colectomy.
Yes. So, like we had that the lesion was close to the splenic flexure. So we had fear that whether we'll be able to mobilize an anastomose or not. but luckily we were able to do it. So like, do any standardize when you have 2 lesions, or you go like a common pathway?
No, I think you will do large left colectomy with, depends of the anatomy of the patient, but with anastomosis between the transverse colon and rectum. But sometimes it's easier to do total colectomy and to do ileorectal anastomosis.
Yeah.
Okay.
But in this case, actually, I think the midcolic vessel has to be ligated so that the transverse column will come to the pelvis. The vascularity of the colon will be depending on either iliocolic artery or right colic artery.
Yes.
Is it not?
Thank you, sir. Thank you.
Yeah. Actually, it's time to wind up, especially Dr. Junji OKUDA. It is 1:30 there in Japan. 1:30 a.m. Monday morning in Japan. So it's better we wind up. There are a lot of other questions in chat box. Actually, we can discuss it later. I'm sorry for not taking all the questions. I think we can wind up now. I thank Dr. Professor Junji OKUDA for joining in the late evening, especially when he was in a holiday trip. Thank you for joining us. Thank you for accepting our invitation. And you have to give us one lecture about your techniques in one of the occasions in Senadvi Education Foundation. And Professor LEROY also has to give a lecture on anastomosis later in one of the occasions of Senadvi Education Foundation. And there are logins from different parts of the world. There are logins from Middle East, logins from Europe, America, Philippines, Japan. There are a lot of logins from different parts of the world. Thank you all for joining. The maximum limit direct participants were 306. Thank you, Professor LEROY, once again for the wonderful lecture, and Professor Junji OKUDA for moderating so nicely. Thank you all for the nice occasion. And I request all of you to join for the next webinar on endoscopic management of surgical indications by Dr. Hari next week. Till then, bye. Thank you all.
Bye. Thank you.
Thank you, Beju. Thank you, Junji.
Thank you very much.
Louis, Sunil, Reshmi, Saji. Thank you all.
Thank you.
Good night, Junji.
Good night. Good night. It's 1:30 a.m. Monday.
Yeah.